Bom dia a todos. Estamos na cerimônia de abertura, na conferência de abertura da 44ª Semana Científica. Não sem antes deixar de agradecer, em nome da minha pessoa e do serviço que eu represento, a oportunidade e a gentileza do convite de estar coordenando esse momento. Parabenizando a diretoria do Hospital de Clínicas, em especial a diretoria de pesquisa, na pessoa da professora Úrsula e na professora Patrícia Prola e a Fernanda Viana, que motivou também este tema. Este tema que diz respeito a uma situação especial que ocorre no mundo inteiro, a diminuição da fertilidade no mundo. Isso é um tema extremamente contemporâneo, é motivo de discussão nos vários congressos recentes na área da reprodução, na área da medicina reprodutiva. Os modelos demográficos estão mostrando uma diminuição da população, e nosso estado, o estado do Rio Grande do Sul, está crescendo a 1,5, ou seja, nós estamos diminuindo a nossa população, e este fenômeno é extremamente atual. E nesse sentido, sem dúvida nenhuma, a pessoa do professor Ricardo Loureiro de Mola, que já esteve conosco aqui no Congresso Brasileiro, já esteve visitando o Hospital de Clínicas, uma pessoa que a gente pode dizer próxima, e a gente agradece a pessoa do professor Ricardo estar aqui. O professor Ricardo é professor e diretor do Departamento de Ginecologia e Obstetrícia da South Illinois University, é diretor do Centro de Medicina Reprodutiva, certificado pelo Conselho da Sociedade Americana e certifica cirurgia minimamente invasiva, endocrinologia produtiva e infertilidade. Ele, sem dúvida nenhuma, vai nos brindar com a sua conferência e depois nós teremos tempo para algumas colocações. Professor Ricardo, muito obrigado pela sua presença online, ainda que não pessoalmente, mas sem dúvida nenhuma teremos oportunidade no futuro, né, de estar com a sua pessoa aqui conosco.
Muito obrigado, Eduardo. Eduardo me pidió dar la conferencia en inglés, así es que la voy a dar en inglés. So you always start with a good cup of Brazilian coffee your day, which is what I've already done. So we'll go ahead and I'll start sharing my presentation for you. Can you see this, Eduardo?
Yes.
Good. So today, and again, I gave Eduardo the option of Spanish or English or Portuñol, and he chose English, so I'll stick with that. And I'm going to be talking today about the future of reproductive surgery, both here in the US and what I see happening around the world. I don't have any conflict of interest on this presentation. And we're going to talk about the state of fertility. And then I'm going to divide the lecture on how things are going to change for the patient, how things are changing with the equipment and the procedures, how we have to create a sustainable environment, and how we need to take care of ourselves in the future. So, as Dr. Passos just mentioned recently, the world population is declining, and it's a very substantial decline that we're seeing basically all over the world. And you can see how fertility has significantly decreased, particularly in developed countries. So you need about 2.3 babies per woman to maintain the population. And there's countries around the world, such as Spain, that the number of births per woman is 0.6. So it's really unsustainable. And when you see the number of children per woman around the world, you can see how that number worldwide has reduced to the point that is unsustainable for the existing population. And you can see how when you look at the number of children in South America, Argentina, Mexico, they're almost the same as it is in the United States or China or Taiwan. Very, very close. So on one hand, we should pat ourselves in the back because contraception works. But on the other hand, we went too far. Or did we? I mean, do we need to have all these many people? And keep in mind, the reason fertility is important is because you have to maintain the population of a country for its economic growth. So this has very significant economic implications for countries. So the only part of the world that's actually growing is Africa. When you look at Brazil specifically, you can see that there's maybe it's less than 2 children per woman. It's actually about the same as it is in the United States and Europe. So whether we like it or not, if we continue this trend, we're going to have to accept that immigration will be the only way to resolve the economic troubles of the world. And that immigration is coming or will be coming from Africa. So when you actually look at fertility and education, there is a direct connection. The more educated women are, the less babies they have because they're spending time during their education. And when you actually see the labor force participation and you look at all countries and you start looking at developed countries like South Korea, Singapore, they're having less than 1 child per woman on the average. But yet you look at Pakistan, Palestine, Iraq, they're having 3, 4 children per woman. And when you actually look specifically at Central and South America, you can see how in the Dominican Republic, Panama, they're keeping their fertility rates. But when you look at Mexico, United States, Costa Rica, they're just not having enough children. So when you actually see specifically the United States, you can see how the population and fertility is distributed across the United States. And there are some states that have a younger population relative to other states. So when you look at this, what's called the Southern Belt, California, Arizona, New Mexico, Texas, Louisiana, all of that belt has a younger population than the upper belt. However, when you look at the country as a whole, the number of reproductive age women remains very stable for several decades at 17.7. So there's the same number of women, but they're having fewer children. Another very significant change that's occurring right now in the United States and in some parts of the world is private equity. These are investors that are choosing to buy medical practices and control medical practices and the objectives. This has already happened in Brazil in some places, but this has been a dramatic change in the United States and is changing the face of fertility, making fertility care more expensive, less accessible, and with more add-ons. In fact, in 2018, 14 and 29% of all cycles had private equity affiliation. Right now, it's over 50%. And it's very interesting, these private equity fertility practices are more likely to do invasive procedures if there's male factor infertility. They're more likely to do pre-implantation genetic testing for patients who don't need it. And they tend to be located in areas where there is a more affluent population. So basically 50% already are owned by private equity. But keep that in mind. We need more babies, we need more children, we need more access to fertility care, yet we're making it more expensive and less reachable to people. The even more concerning piece is that at least 25% of all training programs in medical schools are affiliated with these private clinics. And half the programs now are backed by private equity. So they're actually starting to change the way we train physicians, which is a very significant change in the past 4 years in the United States. Now, politics is getting in the way as well. 86% of Americans believe that IVF should be legal. However, only 20% can afford it. And when you look at the number of children born in the past decade, there's almost been almost a doubling in the number of children born from in vitro fertilization, yet 13 states have pending laws that consider embryos as people. Some of these laws have been reversed and limited in some states, but there's a significant concern that in 13 states in this country, the laws will prevent us from basically freezing embryos, because if you have an accident in the laboratory and you have embryos die, you'll be considered a mass murderer. And this is very concerning, because if this starts happening in the United States, believe me, this is going to happen in the rest of the world. So this is also going to limit the growth of reproductive technologies. And there's all sorts of responses that we have had to try to stop this trend. And the American Society for Reproductive Medicine in the United States have been very active trying to stop these laws. But the second problem we have is that IVF is not a covered service in many parts of the country. I happen to live in a state that has some coverage. Actually, 4 years ago, we were able to pass a law to cover fertility preservation in our state, which was a huge accomplishment. But there is many states that just do not have any coverage whatsoever for IVF and fertility treatments, making it even more difficult for people to achieve care. So what is the future? And I'm going to now start focusing, based on this initial state, what is going to happen and what is happening and what's the direction reproductive medicine is going. It's inevitable. There's going to be more non-surgical treatments. And we're going to see pills, we're going to see devices, we're going to see all sorts of things trying to make fertility happen for people through pharmacology. And the reason for that is that there is a huge market. There is a lot of money to be made using non-surgical approaches. So when you look at the endometriosis treatment market, just North America alone covers 50% of the entire endometriosis market when it comes to medications. Think about that. It's a huge market, and this is not even half of the world. And when you look at the expected growth of the market, we're looking that between now and 2030, there's going to be an annual increase of 13.4% per year, all the way, and that's just in the United States. But when you look at around the world, you can expect that the market just for endometriosis alone is going to be about $1.5 billion by the end of this decade. But we're going to start seeing not only more medications, we're also going to start seeing more devices being generated, and I'll show you a few that are already happening around the world. One example is an infusion system. Rather than injecting yourself with fertility drugs every day, now you can have an infusion system. You can have your phone and control the infusion right up the way and diabetics do right now for insulin. So we're going to see also an adaptation of existing technologies towards the fertility market. And the future is more IVF. There is no question that the role of surgery is being diminished, but we're also going to see more invasive genetic testing, also non-invasive genetic testing, and we're going to see more laboratory automation and artificial intelligence trying to help us. And the reason this is going to be necessary is because we're not training more people. We're not training more specialists. We're not training more embryologists. We're not training sonographers. And the United States, this is a huge limitation to growth. We don't have formal training programs or standards like there are for doctors, for embryologists, and sonographers. And this is much more so in Latin America. So we're going to have to leave some aspects of the IVF laboratory that would be automated to be able to meet the growth and demand expected by the pharmaceutical company and investors. So we're going to start seeing growth in areas like ultrasound being done from home using an app. We're going to start seeing devices that automatically freeze embryos. We're going to see a way to do intracytoplasmic sperm injection, which is injecting the sperm into the egg on a chip in a more automated way, doing genetic testing in a non-invasive way just by taking the fluid from where the embryo grows. We now have devices that are currently in clinical trials, and there's been now live births, being able to inject sperm directly into an egg without the intervention of a human, and of course, more and more sophisticated methods to see embryos grow and be able to identify the embryos that are more likely to give a live birth. And there's also some older technology that's coming back. Now, there's a device called Previvo that basically lavages the uterus to be able to remove the embryos that are inside of the uterus to be able to send them for genetic testing and then returning them back into the endometrial cavity, which is something that was done back in the 70s. So we're going to see a resurfacing of new technologies. But when we talk about surgery, there are going to be some very specific changes that I foresee. And one of them is going to be on planning procedures with the use of three-dimensional printing. This has gained considerable success in other medical fields and in general surgery, and we've not really applied these into reproductive surgery or gynecological surgery. So you take the patient's own radiological image and you create a model of the anatomy of that particular patient with the details, so we can do preoperative planning. We can also use this to discuss with patients the surgery that we're going to do, and it would be an incredible tool to be able to use for student and resident education. We can also create tools for surgery that are specific to that particular patient to be able to approach areas that are not easy to approach. We can also reproduce anatomical parts, but more importantly, we can actually use this technology to print organs. So it is already happening in some areas of medicine, particularly in plastics and in neurosurgery, where you can actually start printing things to be able to care for patients in a better way. But talking about planning, we cannot forget that surgical simulators and augmented reality are going to make a huge difference in our ability to take care of patients and to train ourselves. And these simulators are already available for laparoscopy, for robotic surgery. In fact, our residents in our training program are not able to get on a patient without completing a complete course of simulation and augmented reality through the modules that are available through the robot before they could do the first procedure on a patient. But it's also important for us that are experienced surgeons, where we don't do procedures every day, particularly for rare procedures. So for example, we don't do an abdominal cerclage every day. So this gives us an ability to go in and practice a little bit the procedure before we actually do it on a patient, because it's not a procedure that you do every week, and it helps you to keep your skills. But this augmented reality will also allow us to identify disease to make incisions that are more precise. So a good example is fibroids. Sometimes you cannot see them where you're doing robotic surgery, but with augmented reality, you can see exactly where the fibroid is. You can make a smaller incision that's less invasive, easier to repair, to be able to remove it. On laparoscopy, we're going to see also an increase in the number of three-dimensional images that are currently available. And this is relatively inexpensive technology that's already available to be able to see in 3 dimensions what we can do laparoscopically. We're also going to use more of the narrow band imaging, where we can just with the switch of a button be able to see blood vessels and capillaries to be able to prevent injuries, but also to be able to remove disease more easily. And this is already in use by gastrointestinal, urology, pulmonary, but applications for OBGYN are very possible to help us being aids in the course of surgery. Also, the ability to inject enhancers. So we would be able to actually enhance the images either by the use of 5-fluorescence with aminoleuvaneic acid, or the technology from Firefly, which is existing already incorporated into robotic surgery. So this allows us to visualize the increase in neovascularization, for example, in endometriotic lesions, so to allow us to do better resection, deeper resections if they're necessary, and to make them more targeted to the disease. And this is particularly helpful when we do, for example, bowel resections. When we do a reanastomosis, it allows us to see the tissue viability. So we have less of a risk of perforations and leakage from anastomosis of bowel or blood vessels, for example. Another technology that I believe is going to start replacing certain surgical procedures is going to be high-intensity focused ultrasound. Basically, it's almost like radiotherapy, but instead of using radiation, we're using ultrasound waves. So you can actually take ultrasound waves and direct them to a particular place in the pelvis. And this causes coagulative necrosis and cell death in the tissue that's targeted. You can do this in a non-invasive way, like with a patient sitting on an MRI machine or a CT scan, or you can actually do it with open laparoscopic surgery, where you have like a needle, and at the tip of the needle, you have the high frequency focused ultrasound. So you put a probe, you put the needle into it, and radio frequency waves are sent from the probe to the surrounding tissue. And again, this causes the cells to die. We've also more recently seen some live births associated with this type of surgery. In reproductive medicine, we've been a little leery of using it because we didn't know what the issues would be down the road. But it seems to be a very safe way of treating fibroids, for example. But this could also be used for adenomyosis, for example, where the surgery is much more morbid. You have to resect tissue with it, and radiofrequency waves could easily target the disease. So it would be very easy to place the needle in the correct organ with a combination of images, with a combination of 3D printing or augmented reality, so we can actually see where the adenomyosis is and go in with a needle and just burn that particular area, trying to preserve the anatomy the best way we can and improve fertility. Another use that's already in clinical trials is the use of intensive focus ultrasound for what's called ovarian rebalancing. This is basically what we used to do with ovarian drilling. But instead of doing a laparoscopy or an open procedure, you actually do this in the office transvaginally. And this is now being used for clomiphene-resistant patients. And it could be done in the office under local anesthesia. So you do an ultrasound, you measure the ovarian volume, and the machine automatically calculates the amount of energy that you can release. And then transvaginally, you go in and place the device in the middle of the ovary, and then you just press a button. The radiofrequency kills just the necessary amount of tissue in the center of the ovary. And now some data has shown that 44% of patients will start spontaneous ovulation in the first 3 months, and 65% of patients at 6 months. There's already 8 pregnancies recorded in 23 patients treated in the initial clinical trial. So this appears to be very successful for this patient population. And then with hysteroscopy has historically just been used for diagnosis in the office, but we're going to have to start moving from the hospital to the office, the hysteroscopic procedures. And now that we have mini resectoscopes, we have portable hysteroscopes that are disposable with intrauterine morcellators and tissue recovery systems, laser, and these more miniaturized mechanical instruments that allow us to do procedures in the office much easier. I'm getting a message here. And also, we need to start using the educational devices, the artificial intelligence, augmented reality, to start working on 3D hysteroscopy for the purpose of training providers in this technology to move it from the office to the from the hospital to the office. Of course, robots are another piece of the future. There's new robots that just recently came out that have tactile ability, and these are starting to be purchased by American hospitals. So in my community, in my environment, we have 6 robots available to do surgery. But I expect that there's going to be a change in the way we do robotic surgery, moving to the single port surgical systems. And there's new companies that are now starting to come out, such as Avatera Medical, which came up with a new robotic system, with a much more ergonomic system. We're also going to have companies like CMR from the UK that are making robots that are much smaller and easier to move in and out of the operating rooms. Right now, the robotic systems are so big that you need special rooms that are much bigger to be able to house the robot, and these new ones will be much more nimble, and they could be used in any environment, in any operating room. And we're going to start seeing the combination of software and hardware, like this automated robot that Google and Johnson & Johnson are starting to develop to be able to do surgical procedure in an automatic way. But we're also going to start seeing other new companies come out, like Vicarious Surgical, that came out with a single trocar 12-millimeter robot that's actually far more mobile than the robot available through Da Vinci. And you can see here in this video how mobile this robot is, in a way that is really much versatile relative to the robotic systems that we have today. And it's already available. And we're going to start seeing this more and more. Now, I do anticipate that these new robotic systems are going to be in more ergonomic environments that are going to be better for the surgeon, but also they're going to have the ability to do some automated procedures. So, for example, to automatically tie a knot, to reduce the time it takes to tie knots. And these robots are going to be much smaller. But the move is towards autonomous robots that will be doing procedures on their own. I don't foresee that in the next 10 years, but I do foresee that some of these robots will be doing or be able to do some automatic parts of the procedure. Like I said, tying knots or controlling the temperature of the tissue to not create too much thermal damage, and things of that nature. And of course, nanorobots are going to be something of the future. But none of this is going to happen without artificial intelligence. And again, artificial intelligence is the use of algorithms that allow machines to reason and perform cognitive functions, including problem solving, object recognition, word recognition, and decision making without the input from a human. And I would expect that surgeons will be well positioned to help integrate this technology into modern practice. And I believe there's going to be 4 areas where we're going to see an advance of artificial intelligence in the next 10 years. And that's going to be on machine learning, the development of artificial neural networks, natural language processing, and computer vision. And the ability to take big data and analysis to help us in clinical decisions, it's going to be another area. So for example, for machine learning, we would be able to make predictions about data without programming a particular behavior on the machine. So this would allow us to be able to identify surgical progress in real time. It would tell us if we're making a mistake while we're doing surgery, and be able to assess the surgical field in better ways than we can. With natural language, the ability is the ability to be able to tell the machine verbally what we want, and for the machine to be able to respond and analyze. So for example, you may be in the middle of surgery and you tell the computer, what are the risks that this patient will have postoperatively if I operate for an additional hour, given all the medical piece that we have, and all the medical information that we have on the patient, and can give us an assessment of time for surgery, complications associated with time, whether you need to put antibiotics on this particular patient or not, et cetera, and to individualize the medical care. Right now, we're already using artificial intelligence to, for example, the placement of cochlear implants, and be able to assess the neuronal network and the anatomy of the inner ear to be able to place the implants that are of the correct size and type for that particular patient. And computer vision is already being used in radiology, identifying better than the human eye abnormalities to be able to aid in the diagnosis of pathology. And again, I believe that we need to continue looking at this to be able to better plan surgeries, be able to identify ahead of time intraoperative adverse effects, and be able to use artificial intelligence in surgery to better recover patients and to do better post-operative monitoring and identify patients at risk for complications for surgery. So this is technology that we need to start thinking about and applying into medicine. We also have to start becoming aware of the environment. We all know, and you hear it in the news every day, that climate change is the biggest threat of the 21st century. We in the United States are responsible for 27% of the global healthcare carbon footprint, a third of the waste, and a third of the carbon footprint is coming from a single country alone. And surgery significantly increases the effect on the environment, and we have to be more environmentally sustainable. This is not just an American problem. This is a problem of all industrialized countries, including Brazil. We need to start thinking of removing endocrine disrupting chemicals from clinical supplies. And as obstetrician gynecologists and fertility specialists, we have to foster a culture of sustainability and educate our staff and residents about it. So here's one example. So if you use desflurane for 1 hour for anesthesia, the effect on the environment is the equivalent of 378 miles of driving in a car. But if you just simply switch to isoflurane, you just reduce the amount of driving from 378 miles to only 15 miles. So you would have a very significant reduction on the environment just by switching the anesthetic. So there are 10 ways where we as gynecologists can reduce our carbon footprint. We need to minimize the use of open materials and single-use equipment. We need to reduce the trash, and we need to reduce the energy and that we use in our equipment and shut down equipment. If you walk through operating rooms around the world, you'll see all the equipment turned on for hours and hours and hours, consuming a significant amount of energy unnecessarily when the equipment is not being used. So we need to start thinking of using reusable equipment and to have move to reusable drapes when we operate. We have to start working with suppliers that recycle and reprocess equipment. We need to remove desflurane from formularies and all these toxic pieces of chemicals that are in the medical equipment. And we have to start reimagining an operating room that's more sustainable by education and promotion of sustainability. And we also need to start thinking in the future about ourselves. We are not producing enough physicians for the needs of the world. And we need physicians, and particularly surgeons, to extend their professional lives longer, to be able to care for patients for a longer period of time. So ergonomics become very important. We need to start thinking of surgeons as high-performance athletes. But the problem is that there is this surgical culture that we have to sacrifice ourselves. We don't complain, we just come in, do our work, and it doesn't matter if you're tired, you just need to keep on working. Healthcare has more work-related injuries than manufacturing by a significant difference. So you're less likely to be injured working in an automotive assembly plant than working as a surgeon. And this is something that most surgeons don't realize. And this has a significant negative impact on the productivity and longevity of surgeons. 22% of surgeons miss work days, and 35% do fewer procedures while recovering from the injuries. And our patients are getting bigger and bigger and bigger, creating more stress in our bodies to perform surgery. I don't know about you, but as I've gotten older as a surgeon, when I finish a full work day in the operating room, I mean, my whole body hurts. So we need to start thinking of this and taking care of ourselves, because poor ergonomics increase the risk of carpal tunnel, increase the risk of neck tension syndrome, cervical spine disease, lumbar degenerative disease, trigger finger. I was at a meeting last year with a very well-known surgeon from Europe who does uterine transplantation and cancer surgery. And, you know, he was limping as he walked a little bit and said, "What happened?" "Oh, I just had hip surgery." "What?" "Yeah, I had my hip replaced." This is a guy who is in his early 50s. "Why is that?" "Well, all my hours in the operating room, and I had to have my hip replaced." And he anticipates that he's not going to be able to do surgery in the next 5 years because of all these injuries from being in the operating room. So we need to start thinking of this. This is not a joke. In this particular case, a world-renowned surgeon who's going to have to quit prematurely his practice because of injuries from work. I mean, this is just unacceptable. So we need to start thinking, when we do open surgery, to have the correct anatomical position, the correct height of the table, the correct angles. we need to also, when we do laparoscopic surgery, that the instruments are properly placed, where we're placed with our shoulders slightly retroverted, with a straight back, using anti-fatigue mats, and the TV screen at the right angle, in that our elbows and shoulders are in the correct position to do surgery. And when we do robotic surgery, same thing. We need to really start thinking of these kinds of things. And what are the risks for having injuries in the operating room? Well, the gender of the surgeon becomes important, the size of the surgeon's hand. Also, surgeons of shorter stature and smaller body mass index are at the highest risk for having injuries. And who am I talking about? Women surgeons. So women surgeons are more likely to have injuries from surgery than male surgeons. And for any of you in your medical schools and around the world, just look around who's coming to medical school. In the US, 60% of new medical students are women, and 90% of all OBGYN residents are women. I'm sure it's the same in Brazil. So we need to start thinking that our surgeons are changing, and we need to have environments that are more friendly to women, and to make equipment that's properly sized for women. So right now, the surgical equipments are really made for a 7.5, 8 hand size. So it is harder to reach things. It is harder to operate the equipment. It is difficult to reach the rotating knobs, the loops, etc. It's harder for women to do surgery because the instruments are not made for their hands. So we need to start putting pressure on the makers of surgical equipment to make it appropriate size for different size of hands, and not make a single size for all surgeons. This, I mean, I see this in my residents where they have to use 2 hands to be able to operate the equipment. And they're more likely to end up having pain and digital neuropraxia and paresthesia at the end of a surgical procedure because the equipment is not made to their hands. We also need to start thinking about exercising and stretching, and we need to think of ourselves as athletes. There is no athlete that goes and runs 10 miles without some warming exercises. So we need to start thinking of that the same way. There are specific finger stretches of hands and fingers that we can do intra-op and between cases to stretch our fingers, also to stretch our backs, our legs, and to be able to rotate the arms, to be able to keep us warm, and also to stretch our muscles, to be able to reduce injuries. And another area is coaching. And we were used to having this relationship when we were all medical students and residents with our mentors and professors, where it was really a top-down type of relationship. I'm the professor, you're the learner, and you do as I say. But a coach is very different. A coach is another surgeon that partners with the surgeon and provides one-on-one guidance to improve the personal performance of the surgeon. Surgical coaches are trained on the principles of coaching, setting goals, action planning, and holding surgeons accountable when they make mistakes. And they don't have to be in your same discipline. And there is a surgical coaching academy by the American College of Surgeons that is doing that right now. And how is it different to teaching or mentoring, which is really the relationship that we're familiar with in medicine? It's different because A teacher provides knowledge. A mentor guides the mentee. But here it's different because a coach is a co-learner. It's not necessarily an expert, and it attends the surgeon's needs. If Michael Jordan or Lionel Messi or any professional athlete has several coaches to improve their performance, even though they're world-class athletes, why can't we have coaches to improve our ability to be better surgeons and to do a better job in the operating room and learning from an outsider? And that's part of what happens in the OR. You're the surgeon, you call the shots, you tell everybody what they need to do, but are you really doing a good job? And that's where the coach comes in. But I do believe that a lot of these innovation that we're going to see in the future will come from multiple technologies. There is this paper of this gastrointestinal provider who was working in Africa, and his endoscope broke, so he was able to adapt his cell phone to be able to provide the light, to be able to provide care for patients. And there's apps and devices to localize needles, procedures, and even analysis that could be done with an app. I mean, we're going to start seeing more and more of these technologies that are going to start merging. And that's how we're going to start probably applying a lot of these technology. So what's the future? From a patient's perspective, we're going to see more non-surgical treatments and IVF. There's no question. The problem is going to be who's going to control that? And is that going to make it more expensive and more difficult to attain for patients? That we're not going to reach the goals that we need to reach. We're going to see more diagnostics and surgical treatments that are non-invasive. And we're going to see more of the add-ons like PGTA and biopsies and all sorts of things as well. We're going to see more automation of patient and IVF laboratory management. And artificial intelligence is going to help us improve diagnosis, management, and outcomes. I expect that we're going to have the ability to do 3D printing, simulators, 3D vision, move hysteroscopy to the office, and more of the use of robots and artificial intelligence to help us guide decision-making in the operating room. We're going to have to take care of our environment. We're going to have to be more conscientious of eliminating things that are toxic and that are bad for the environment, because the footprint of surgeons is quite wide around the world. We're going to have to improve our ergonomics and to think about coaches. We have to recognize that surgeons are the elite athletes of medicine, and that it takes us many years to acquire that knowledge, that skill, and that experience, and we rarely consider our own well-being. And we need to start making equipment of various sizes to accommodate the different size hands of surgeons, particularly now that we have more women surgeons in the workplace. And to start thinking about education and intervention through stretches and exercises and breaks between surgeries to keep our bodies healthy. Again, surgeons are the elite athletes of medicine, and therefore we should have a coach. Even Michael Jordan, Lionel Messi have multiple coaches. Why not us? And again, the coach is a co-learner, not an expert in what it is that you do, but it would improve our ability to do better surgery and take care of our bodies much better so we can have longer professional lives. Again, without change, there's no innovation. There's no creativity or incentive to improve. Those who initiate change will have a better chance of managing the change that is inevitable. Whether we like it or not, this is coming. I have been in reproductive medicine for not almost, for 3 decades now. And I had to reinvent myself at least 3 times in what I do with change. And I anticipate I'm going to have to reinvent myself again in the future. So I think we have to keep in mind that this is a reality, that we are to experience change and we have to be ready for it. So thank you very much. I'll be happy to take questions. And thank you again for your time and being here with us today.
Thank you very much for a nice presentation. Nice presentation, talking about everything that we choose for the thematic of this scientific week, which means healthy and prevention life. Health prevention and life healthy. And
we always think of that, Eduardo, for patients.
Yes.
We don't think of that for ourselves.
Yes.
And the place we work and the environment that we work. And we need to start thinking of this. And that is something that is not embedded in the surgical culture or the training of doctors. And we need to really start thinking of that. We're not training enough doctors for the needs of the world. So we need to work longer and stay healthy for a longer period of time.
That's very important. And very important is one thing that talking about the population growth, that we need to discuss in the medical schools of education for reproductive counseling, because the people are trying to get a family and to have children longer in their life. So they don't know that the ovary and the healthy fertility will diminish along the life of the woman, especially the woman. And we inform the population, it will inform our medical schools, our medical students, because they, even in other specialty, they have to talk about reproductive ideas with their patients.
And we need to also start thinking that all these reproductive technology, Eduardo, the way it's going, we need to think about this as a form of family planning. So where couples, women, families can choose when they have their family and their children. So you may be at a point in your life where you don't want to have children, so you need contraception, but maybe you need fertility preservation. So you can decide when to build your family and how many. And these technologies, as they are today, with the great contraception that's available, with the better outcomes from fertility treatments, where women today can truly choose when to have their children and have control over that, better than ever before in the history of humankind.
Even though the population doesn't have the right information of the better years of having healthy oocytes to have the children. So the fertility preservation in some situations, oncology, oncofertility, but even in a social way, we must talk about with our patients. And even though there is a kind of government health politics, because as you talked, business and health is very conflicting sometimes, but in the way we have to development, thanks for the development of the industry, but business and healthcare, it's a kind of better discussion should be done.
I mean, another example, Eduardo, the fact that our medical students and residents spend the better years of their reproductive life in training should we offer all residents and medical students the opportunity to preserve fertility as part of training programs? When you actually look, and there was a study done by a group of people from Rush University in Chicago, when they actually asked universities and medical schools about fertility preservation for their students, essentially nobody does that. And is this something that perhaps we should start thinking about and having a conversation with leaders of medical schools and hospitals about offering that to those individuals? I'm sure, and I know that you've been doing reproductive medicine for as long as I have. You know, the percentage of doctors that we see as patients who couldn't have children because they dedicated their life to caring for patients, and then we cannot care for them. It's ludicrous. I see every day one or two physicians who cry in my office that they wish they understood what fertility was like and had made different decisions in their life. And every day, one or two physicians, at least. I'm sure you have the same thing in Brazil.
Yes, yes, for sure. Especially because the age of the medical students are more high today. I don't see if there's any other questions, and we finished the time of the opening ceremony. And thank you very much, Ricardo, for staying with us and with your very nice presentation. Hope to meet you in the next future. Thank you very much.
I'll see you soon, Eduardo. Thank you.
Ricardo, bye-bye. Thank you again.
Take care.
Best for you and your family.